Hi, this is Dr. Chad Deal. I'm Associate Professor of Medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University and head of the Osteoporosis Center at the Cleveland Clinic. I'm going to spend the next 15 to 20 minutes reviewing osteoporosis with you as it related to the 2012 ACR annual meeting. The first few slides are going to be related to Denosumab or Prolia, which is a drug that was released in the United States in 2010 and is a fully human monoclonal antibody against rank ligand. This slide, which is abstract 1959, shows the fracture incidence in Denosumab long-term extension trial and both the first 3 years and years 4 through 6. The Freedom trial was the randomized control trial that led to the approval of Denosumab, and that's presented on the left of the slide in the first 3 years. At the end of those 3 years, patients were offered a 7-year extension, and this is the years 4 through 6 data. So in the overall population, you can see that vertebral fractures were reduced by 68%. And in the open label portion, there's no control group here. Vertebral fractures were reduced by 51% in the next 3 years. On the right part of the slide is a subset of women in this study who were over the age of 75. And you can see the fracture efficacy in the first 3 years for vertebral fracture was 57% reduction, and in the open label period, years 4 through 6, a 64% reduction. So this long-term extension indicates continued fracture reduction in patients who are on Denosumab at least through 6 years. This slide presents exactly the same data except on non-vertebral fractures, and this is probably even more interesting because the non-vertebral fracture reduction in the overall population was 20% in the first 3 years, but 52% in years 4 through 6, again without a control group. And the same thing was true in the 75-year-olds, a 12% reduction in the first 3 years and a 40% reduction in years 4 through 6. So it almost appears that there's increasing efficacy over a longer period of time for non-vertebral fractures with this drug. The same thing was found for hip fractures, again, abstract 1959, showing a reduction in hip fractures in the first 3 years and then total population of 40%, and in years 4 through 6 of 66%, and again in those over the age of 75, 61% reduction in the first 3 years and 57% in years 4 through 6. And you can see the numbers in all these slides. There are about 2,343 patients in the overall population who got 6 years of Denosumab therapy. So the question is why there may be increasing efficacy over time with this medication. This is abstract 824 at the ACR meeting, and you can see the slide shows an increasing cortical mass over a 3-year period in a subpopulation of the Freedom trial. The number here is 80 who had QCTs. So you got about a 5% increase in cortical mass during the 36 months of this study. About 1/3 of that increase in mass was related to increase in cortical density, and about 2/3 was related to an increase in cortical thickness. So this drug not only increases density, but increases the width or the thickness of cortical bone, which is a mechanical advantage since increasing diameter increases strength to the third power of the increase in diameter. At last year's ACR meeting, this is abstract 631 from 2011, there was a head-to-head trial comparing placebo, Alendronate, and Denosumab for what we call cortical porosity. You can think of cortical porosity as holes in cortical bone, and this just represents remodeling in cortical bone as opposed to what we see in trabecular bone. This study was a study of 247 women looking at porosity by high-resolution PQCT, and you can see that their Denosumab resulted in a significant reduction in cortical porosity compared to placebo and compared to Alendronate, so it appeared to be more effective at reducing cortical porosity, which would increase cortical strength than alendronate therapy. One question that's often asked is the relationship between baseline bone density and the change in bone mass over time. And Abstract 1977 addressed this issue for Denosumab again. It makes intuitive sense that patients with high bone resorption markers might respond better to an anti-resorptive agent such as Denosumab or the Bisphosphonates, and this study addressed that issue. And you can see for the lumbar spine, for the total hip, for the femoral neck, there appeared to be a relationship between increasing bone mass in patients with higher bone turnover based on the bone resorption marker serum CTX. However, you can see the p-value for this trend was greater than 0.05, so it wasn't significant. Probably another important point here is that even in patients in the lowest tertile for bone resorption, did increase their bone mass with an anti-resorptive agent, indicating that it's worth treating patients at all levels of bone turnover based on serum CTX, and probably this is applicable to urine NTX, which is another common marker for bone resorption that we use in the clinic. Abstract 1998 dealt with the relationship between bone density and fracture after 6 years of Denosumab treatment. Through 6 years of the long-term extension trial from Freedom, you can see the increase in lumbar spine density on the right of the slide was 15.2%, a very robust increase in bone mass. Total hip density 7.5%, and femoral neck 6.7%. 99% of patients had a gain of greater than 0%, 98% greater than 3%, and 95% greater than 6%. So obviously most patients will respond to Denosumab with an increase in bone mass. Interestingly, you can see there's quite a strong relationship between the increase in bone mass in the lumbar spine, that's the top part of the left hand of this slide, a strong relationship between bone build or increase in bone mass and fracture reduction. So you can see from 0 to 14%, there's a gradual decline in the predicted incidence of new vertebral fractures with increasing bone mass. That relationship is not nearly as strong on the bottom graph of this slide when using non-vertebral fractures as your parameter. And again, this is from the extension trial, and the number of patients in this is large, 2,343. Abstract 1961 is a new technique that you may be hearing about for those of you who have a bone densitometer or will see bone densitometry studies. This is the change in trabecular bone score with Denosumab, and it shows basically an increase in trabecular bone score over the 3 years of this trial. This is 285 patients with an average T-score of minus 2.79. This trabecular bone score, or TBS, has been shown to correlate with fracture risk and is related to microarchitecture, and it is done on a routine DEXA of the lumbar spine, so it requires no new hardware, but unfortunately does require new software, and this is actually FDA approved now in the last few months of 2012. But the software cost is around $10,000, so it's pricey. This is the concept, TBS in trabecular bone. TBS is a novel grayscale texture measurement based on 2D image extracted from the DEXA image. It's correlated with the 3D characteristics of bone microarchitecture and appears to be independent of the DEXA in terms of fracture prediction. A low TBS correlates with low connectivity density, that is how the struts are connected together in trabecular bone. It correlates with high trabecular spacing if there's a low TBS score, and reduced number of trabecular, and again, it is a predictor of fracture risk independent of spine and hip bone density. And that's conceptually shown here. On the left, you can see a vertebral body, and on the right, the microarchitecture pictures of that vertebral body, and you can imagine the DEXA scan passing through the bone in the vertebral body, and when there's lots of trabecular spacing and lack of connectivity, you can divide up into pixels, and you can see on the right bottom B part of this slide that there are lots of holes in the bone represented by dark pixels. This is a low TB. This would represent a low TBS. And a cohort from Canada, the Manitoba cohort, where they do bone densities on everybody over the age of 65, and also since they have a national health insurance, are able to capture all the fractures in the population. You can see along the X and Y axis of this that when you have a low lumbar spine TBS, the lowest tertile, and osteoporosis T-score minus 2.5, you can see that's where the fracture risk is the highest. That's 25 per 1,000 patient years. So the combination of low TBS and osteoporosis is the best predictor for fracture incidence in this population, and those two are somewhat independent and additive. So that's this cohort is a cohort of over 29,000 patients with over 1,600 fractures. So again, it's a robust cohort. Nitroglycerin has been used for in experimental trials in both animals and in humans for osteoporosis for some years now. This was a study by Sophie Jamel that appeared in JAMA in 2011 and showed an increase in lumbar spine and in hip density in 243 patients who were given nitroglycerin ointment, 15 milligrams in the evening. 126 got the nitroglycerin, 117 got placebo, and you can see that both in the lumbar spine and in the hip bone density increased. And in previous trials, nitroglycerin is interesting because it's both an anti-resorptive and an anabolic. You can see that NTX, a marker of bone resorption, declines about 45%, and BSAP, bone-specific alk phos, a marker of bone formation, increased by 23%. So it's a very interesting compound. It's very inexpensive. In this study, really the only side effect with this compound was headache. If given at night, that is not a significant side effect. Abstract 1980 at this year's ACR meeting looked at the relationship between hip fracture and intermittent nitroglycerin use in 14,925 users versus the same number of non-users with an average age of 73 years. The users had 267 hip fractures. The non-users, 332 hip fractures, which represented a 30% reduction in hip fractures in nitrate users with a p-value of 0.001. So this appears to be something that could be considered as an alternative therapy for osteoporosis, especially in patients who are intolerant or can't take other therapies. So it's not approved for this use, but it's something that you can consider in the future. Atypical hip fractures are a big topic. A big problem with long-term bisphosphonate use in Abstract 1974 was really a meta-analysis of atypical hip fractures from multiple studies. This slide shows the ASBMR case definition of atypical femoral fractures. The major features are that it's located anywhere along the femur from just distal to the lesser trochanter to just proximal to the supracondylar flare. The fracture is transverse or short oblique in configuration. It's non-comminuted. Complete fractures extend through both cortices and are associated with a medial spike. Incomplete fractures involve typically only the lateral cortex. They're associated with no trauma or minimal trauma, such as a fall from standing height or less. The case definition really requires all 5 of these major criteria. The minor features include this localized periosteal reaction of the lateral cortex, and this actually may become a major feature in the new revised criteria, which may come out in 2013. There's a generalized increase in cortical thickness of the diaphysis. There's often a prodrome of dull aching pain in the groin or thigh. These fractures are bilateral in up to 25% of cases, and they often have delayed healing. There are often comorbid conditions such as vitamin D deficiency or rheumatoid arthritis, and they're associated with pharmaceutical agents obviously bisphosphonates, but also steroids and PPIs. So the next few slides illustrate the points I've just made. This is an Xray of an atypical fracture. You can see the major criteria. It's below the lesser trochanter. It's a transverse or short oblique fracture. You can see the medial spike. You can see that it's non-comminuted, and that the patient history was no trauma. The minor criteria I mentioned is this localized periosteal reaction, which represents a stress fracture on the lateral cortex. When the plain X-rays are not obvious in terms of diagnosing this condition, both bone scan and MRI can be diagnostic, as you see here. There's an increase a focal increase in uptake in the bone scan that's consistent with an insufficiency fracture. And on the bottom part of the slide, you can see the MRI has a decreased signal on the T1 image, and on the T2 image, an increased signal indicating edema in the cortex, which is consistent with a stress fracture. This publication is from the Cohort study from Northern California by Rick Dell, who's an orthopedic surgeon in that population, and it shows the increasing incidence of atypical fractures based on duration of bisphosphonate exposure. You can see that after a period of about 5.9 years, there's a significant increase in the number of these atypical fractures. Up to 8 years, the rate is 113 per 100,000 patient years if used for over 8 years. I think it's important to realize that typical hip fracture incidence in randomized control trials is around 750 to 833 per 100,000, or 7 to 8 times the incidence of these atypical fractures. So if you combine the data in the literature from Rick Dell and others and look at the randomized control trials that have been published that give us an idea of the efficacy of bisphosphonate therapy for reducing fractures, you can see that the number needed to treat with a bisphosphonate for 3 years to prevent one fracture is 91, and for a radiographic vertebral fracture, 14. The number needed to harm with an atypical fracture over 3 years, based on the data we have so far, is about 417. So that means for each atypical fracture caused, at least 30 vertebral and 5 hip fractures are prevented. The treatment of these is evolving. If there's a thigh pain prodrome in a patient on long-term bisphosphonate therapy, please image the patient with an X-ray or bone scan or MRI if needed. The bisphosphonate should be discontinued until you're sure what's going on. An image of the contralateral hip is recommended since these are bilateral in 25% of cases. Reduced weight bearing should be done immediately with crutches. The fracture should be staged, and if there's a stress line, usually an intramedullary nail is placed, but the non-union rate of even intramedullary nail is actually quite high. There have been several case reports now of teriparatide as treatment for these, since this drug will increase bone formation and bone resorption, and the presumed etiology for the atypical stress fracture is low turnover and adynamic bone. Abstract 727 and 991 deal with a new medication that's not on the market yet, Odanacatib, and they deal with bone density and cortical bone. Odanacatib is a CAT-K inhibitor, and that's illustrated in this slide. This is an osteoclast, and in order for an osteoclast to resorb bone, it needs to secrete not only hydrogen to resorb the mineral matrix, but it needs to secrete cathepsin K to resorb the matrix, such as collagen. And Odanacatib essentially inhibits cathepsin K excretion. This is the literature we have so far on Odanacatib. You can see on the left that the increase in bone mass through 5 years of Odanacatib is quite robust, 11.9%, and the year-on-year increase with this drug is impressive and doesn't flatten out as the bisphosphonate bone density increases do after about 3 years. But you can also see after 24 months of therapy, when the Odanacatib is discontinued, that there's a rapid loss of bone density at discontinuation. There's also, you can see on the right, there's a rapid resolution of resorption at discontinuation of the Odanacatib, so the NTX value goes up very rapidly, and again, that's very different than discontinuing a bisphosphonate, where the effect of the bisphosphonate is prolonged in bone. The effect of Odanacatib is reversed very quickly on discontinuation. In addition, this drug appears to have less suppression of bone formation than the bisphosphonates. You can see on the bottom graph with P1NP that P1NP levels do go down in the first 3 to 6 months, but notice that they gradually rise over the rest of the 24-month period and are back to baseline at 24 months. So this means less inhibition of bone formation may mean greater increases in bone mass over time than we see with the bisphosphonates, which is what you appear to be seeing with the data through 5 years of Odanacatib therapy, an 11.9% increase in lumbar spine density. This drug appears to be effective. The registration trial for this drug was stopped in July of 2012 by the Data Safety and Monitoring Board, not because of a side effect, but because it met its co-primary endpoints of both vertebral and hip fracture, and the secondary endpoint of non-vertebral fracture. We do not have any of the data on this. We just have the word from the DSMB that it met its both co-primary and secondary endpoints, presumably. So the study is being closed, and the data is being analyzed, and the data will be submitted to the FDA, and this drug is expected to be released in 2014. The last thing I want to talk about is Wnt signaling and a new drug that's going to be available, but probably in the 4 to 5 year time frame. This slide shows a skull X-ray in 2 patients with sclerosteosis. Sclerosteosis is a condition caused by a gene mutation which results in a sclerostin deficiency, and we'll talk about what that means. On the left is a child with sclerosteosis. The middle skull is a homozygous adult with sclerosteosis, and you can see the increase in bone density in this skull, which results in entrapment of multiple cranial nerves. And on the right, you can see a skull of a patient with a heterozygous form of sclerosteosis. So they have an intermittent, a bone density that's intermittent between a normal and a homozygous with sclerosteosis. So in order to understand the drug that's coming down the pike, you need to understand Wnt signaling, which is illustrated here. Wnt signaling is important for bone formation, and the major players here are membrane proteins, including frizzled and LRP5. And when Wnt is present, these 2 membrane receptors associate and assemble a protein scaffolding complex, which you can see has beta-catenin in it. Beta-catenin is released and transported to the nucleus, where it upregulates Wnt-responsive genes, which are osteoblast-related genes. Without Wnt, this doesn't occur. Beta-catenin is phosphorylated and is not available, and Wnt signaling does not occur. Sclerostin, or SOST, is an inhibitor of Wnt signaling. It's secreted by osteocytes, and when present, bone formation is reduced, and Wnt is not effective. In patients with sclerosteosis, which is a SOST deficiency, there's a deficiency of SOST, so Wnt signaling goes on at rapid pace, thus the increase in bone mass that you saw in the previous slide in the skull. An antibody to SOST has been developed and takes SOST out of circulation, so it has a very similar effect to sclerostin deficiency and results in increase in bone mass. AMG 65, now termed romosozumab, is a fully human monoclonal antibody against sclerostin, which in a phase 2 trial in 419 postmenopausal women showed a significant increase in bone mass compared with teriparatide and alendronate, as seen on this slide. So you can see the increase in bone mass with AMG 785 or romosozumab at 12 months was 11.3% compared to teriparatide 7.0% compared to alendronate 4.0%. So a much more robust build in bone. One advantage of this product over current anabolic agent teriparatide is it's given on a once-a-month sub-Q injection versus daily compared to teriparatide. In addition, while P1 increases very robustly, i.e. it's an anabolic agent, it increases osteoblast function, CTX, a marker of bone resorption, decreases by 50%, and with teriparatide we know that bone resorption is increased.